The second a joint replacement patient rolls through the hospital exit, the care team loses all visibility into their recovery. This creates a dangerous 14-day blind spot. Under the U.S. value-based care mandate, a federal healthcare delivery model that ties Medicare payments directly to the quality of care provided, hospitals face massive financial penalties if that patient is readmitted within 30 days. At home, two specific risks drive these readmissions: undetected surgical site infections and severe opioid mismanagement. Once the patient is in their own living room, the hospital has no way to track either of these vectors. Doctors cannot see if an incision is inflamed or if the patient is taking pain medication on schedule. Without continuous post-discharge telemetry, recovering patients become unpredictable financial liabilities for the hospital. Legacy electronic health record portals like Epic MyChart or Cerner cannot solve this. They are passive filing cabinets designed for static data review, not active at-home monitoring. Hospitals attempt to bridge this gap by hiring call centers or outsourced nursing staff to conduct manual check-ins. It is an expensive, low-fidelity process that relies entirely on a patient accurately remembering their symptoms over the phone. The industry assumes the fix requires building complex Smart on Fire API integrations. Smart on Fire is a data standard that allows external applications to access electronic health records securely. The assumption is that telemetry must flow continuously into a centralized cloud. But routing raw, protected health information into central cloud servers immediately triggers strict HIPAA Business Associate Agreement, or BAA, liabilities. A BAA is a legal contract required by law to protect patient data when shared with third-party vendors. Centralizing this data creates a high-value target for ransomware. To capture high-fidelity post-op data safely and economically, hospitals must bypass centralized cloud APIs entirely. The infrastructure must be pushed directly to the edge, the patient's local device. This is the architecture of Aura hOS, operating as a surgical blackbox. It is a local-first application that transforms the patient's own smartphone into an immutable edge ledger. All telemetry is stored in an encrypted SQLite database, a lightweight, localized data storage engine. It is secured using AES 256 GCM, a military-grade cryptographic standard, with the decryption key tied strictly to the device's physical hardware secure enclave. This chart captures the opioid tapering protocol. Patients log intake times for prescribed analgesics alongside over-the-counter step-down medications. This log binds to a daily subjective pain scale. Under a zero-knowledge paradigm, developers do not possess decryption keys, rendering data completely opaque to cloud breaches. This mathematically sound, patient-sovereign tapering chart replaces the flaws of subjective human memory. It provides the care team with an unalterable record of adherence. Tracking this data introduces a severe regulatory trap. If a software application independently analyzes post-op telemetry to alert a patient of an impending infection, it crosses a strict legal threshold. That behavior classifies the software as a medical device, or SAMD. This subjects the hospital and developer to stringent FDA oversight and massive diagnostic liability. Aura hOS systematically avoids this strict classification. It operates entirely under the 21st Century Cures Act non-device exemption, acting strictly as an information summarizer rather than a diagnostic tool. This graphic shows the absolute regulatory boundary. The software is hard-coded to never calculate health correlations or issue diagnostic directives. It enforces this using client-side regex sandboxes, search patterns that block specific text strings. These physical constraints prevent the on-device AI from hallucinating medical advice. By strictly refusing to automate the diagnostic process, Aura shields the hospital from SAMD liability while aggregating the precise raw data required for human review. The surgical black box also tracks the second major risk factor, objective visual evidence of the surgical incision site. A daily prompt requires the patient to capture a photograph of the healing incision. This image is instantly encrypted into their local vault alongside their daily vitals. If a patient asks the Aura AI if their incision looks infected, the system initiates a compassionate deferral. It refuses to diagnose the image and immediately surfaces an actionable routing button to contact their doctor. The AI functions exclusively as a documentation assistant. It formats unstructured patient voice notes and photos into rigidly structured clinical timelines. This timeline perfectly aligns polypharmacy records, the concurrent use of multiple medications by a single patient, with subjective symptom logs, without ever altering the raw source data. This architecture perfectly preserves the chronological reality of the patient's recovery. It explicitly shifts the burden of diagnostic accuracy and correlation back to the licensed human physician. On day 14, the telehealth follow-up begins. The question is how the physician securely accesses this edge ledger without breaking encryption. The solution is the Transient Handshake Protocol, or THP. This protocol serves as a bidirectional bridge for frictionless data ingestion between patient and clinic. The patient generates a secure ephemeral QR token. This token contains a 0SSN unique patient identifier and the encrypted payload of their recovery data. The clinician scans the token, establishing a direct WebSocket tunnel. This real-time connection tunnels data from the patient's local cache straight to the provider's browser, completely bypassing the need for complex Smart on Fire API gateways. The THP eliminates interoperability friction entirely, making the patient the ultimate sovereign transporter of their own cryptographic medical history. Once the payload decrypts on the physician's screen, they see a perfectly formatted chronological dashboard featuring the daily incision photos, the subjective pain graphs, and the exact opioid tapering log. Using this pure chronological metadata, the physician can spot subjective markers of an infection days before a formal fever spikes, interceding before it triggers an emergency room visit. This enables a massive financial pivot. Turning the patient into a continuous data endpoint legally transforms a post-op cost center into a revenue generator. Receiving this structured telemetry unlocks remote patient monitoring, or RPM, Medicare billing codes. Specifically, codes like CPT 99453 and 99454. CPT, or Current Procedural Terminology, codes are standardized numeric identifiers used to report medical procedures to insurers. These RPM codes generate a predictable, recurring monthly revenue stream strictly from monitoring the patient-generated digital health data. By decentralizing data capture and routing it securely to the provider, Aura hOS closes the 14-day blind spot. It eradicates the value-based care readmission penalty and scales institutional capacity without compounding regulatory liability.